My name is Alexis Johnson. I'm the social media manager here at RSDSA. I'm joined by Jim Broach, Executive Vice President and Director of RSDSA. And our final Facebook Live guest for 2022, Dr. Carolyn McMakin, to discuss treating CRPS with frequency specific microcurrent. Dr. Carroll is the clinical director of the Fibromyalgia and Myofascial Pain Clinic of Portland, Oregon. She developed frequency specific microcurrent, FSM, in 1995 and began teaching FSM courses in 1997. In addition to maintaining a part-time clinical practice, she teaches seminars on the use of FSM in the United States, Canada, Australia, Ireland, the UK, Europe, Taiwan, and the Middle East. She has lectured at the National Institutes of Health and at medical conferences in the US, England, Ireland, and Australia on the subjects of fibromyalgia and myofascial pain syndrome, fibromyalgia associated with cervical spine trauma, and on the differential diagnosis and treatment of chronic pain, pain syndromes, and sports injuries. You can sign up for an FSM seminar, watch FSM videos and webinars, find the frequently asked questions and all of the published and unpublished papers at frequencyspecific.com. And of course, we will add that to the chat. Dr. Carroll's bio is amazing, and I will copy and paste it into the chat here on Facebook and into the description on YouTube. And as always, remember that while the information shared here is helpful, please consult your physician for personalized medical advice. All right, Jim, do you have any announcements before we turn it over?
Just quick, warm welcome to our returning guests and any new guests. And we really would love to have your input about future Facebook Lives. We're very open to your suggestions. So you could send us an email at info@rsds.org. Two final things. As we approach the end of the year, we're having an auction that has some very unique items. I would love you to look at that. We'll put the link there too. And also, finally, we're doing our end of the year campaign, and we'd love you to consider a gift. Any amount would be greatly appreciated. You can either make a one-time gift or a monthly gift if you could do it over time. And listen, hope that we're your favorite charity. And if we don't talk again, listen, have some beautiful holiday days, and I hope your pain is low. Alexis.
There you go. I think you covered it. And we will be sending out the winter 2022 edition of In Rare Form within the next couple of weeks. So definitely keep an eye out for that. But all right, enough of us. We will turn it over to Dr. Carroll.
Hi there. This is Carolyn McMakin, and I got to be one of the few people I know that loves treating CRPS. We started treating it in, hang on. Oh, you've got to be kidding me. Come on. I started treating it in, this worked a second ago. I started treating it in 2000. There it is. Got it. I started, the frequencies that we used with FSM were first used in the 1920s, and I got them from an osteopath who bought a practice in 1946 that came with a machine that was built in 1922. And I got the frequency list in 1995, and we started treating just muscle pain. I taught it in 97 to find out if the results were real. We started with 10 practitioners. By 98, I started treating nerve pain. 99, a patient came in with fibromyalgia and RSD or CRPS and treated that successfully, continued to teach FSM. And by 2022, there are 5,000 practitioners in 23 countries. So the results are teachable and reproducible. There's never any guarantee, but research in animals and humans have accumulated, and now there's 15 peer-reviewed papers and 2 books. So we have animal research that shows that the frequency to reduce inflammation in a mouse model, so there's a little mouse, this is the control group, and you paint arachidonic acid on the mouse's ears, and the mouse's ears swell up this much, then you do something to the mouse. you give it an Advil or Toradol, or you use a frequency. And in this case, the frequency to reduced inflammation by 62% in lipoxygenase-mediated inflammation, 30% in COX-mediated, which is equivalent to injectable Toradol, which they use after surgery. There's no animal it didn't work on, and it was time dependent. The paper that we published that had the most impact was published in JBMT in 2005. It had 54 fibromyalgia patients with a history of some sort of trauma, chronic from 1 to 50 years. And I sent a blood sample to a microimmunochemist at NIH. I presented the case reports at NIH in 2000. And he sent me some blotter paper. We sent him a spot of blood, and he produced data. But recognizing the patient was this characteristic full body pain pattern. They had to have hyperactive patellar reflexes, specific nerves that were hypersensitive. And we found clinically there was only one combination that reduced body pain, and that was the frequency to reduce inflammation in the spinal cord, because that was the only thing that explained the full body pain. And what we found was that all of the inflammation that causes nerve pain dropped by factors of 10 and 20 times. Substance P, which is interpreting pain or transmitting pain in your spinal cord, dropped by logarithmic rates by factors of 10 and 20 times in 90 minutes. And the body pain went down from an average of a 7 to an average of a 1, last any place from 2 hours to 2 weeks. 2 patients where it was permanent after 1 session. All patients had pain relief, and about 60% recovered within 4 months. There were 13 out of 54 that discontinued treatment for reasons not related to treatment side effects. But I think it's more because when your pain goes from a 7 to a 1 in 90 minutes, at the end of 90 minutes, there's an identity crisis that's pretty much unparalleled in medicine. So there's a paper published in Simple Neuropathic Pain from Disc Injuries or Traction Injuries. Once again, all patients had pain reduction. Some of it was lasting. 65% fully recovered in about 5 sessions. There's no adverse reactions, right? So how does this happen with just frequencies and microcurrent? Because we're using a standard microcurrent device approved by the FDA as if it's a TENS device, and we're using frequencies from the 1920s. So how does science explain the observed effects and objective findings? Well, Newtonian physics describes large objects, but fails to describe the behavior of molecules. And your body is a large object made of molecules, atoms, subatomic particles that are all held together by electromagnetic bonds, and every bond has a frequency at which it resonates. So how does the body conduct current and frequencies? We don't think of ourselves as electromagnetic beings, but we are. There is water that lines the gel inside the cells. There's a gel matrix inside the cells, and water molecules line them and form structures that really resemble silicon, like silicon chips that are inside your computer that conduct current, charge, and information. So according to biophysics, your body's an electromagnetic system that looks solid, but the cells function as a semiconductor network, like a computer chip that conveys current, charge, and vibrational information. So Frequency Specific Microcurrent, the book that I published, is called The Resonance Effect. What's resonance? Well, resonance is the tendency of a system or a bond to oscillate at large amplitudes in response to some frequencies and not others. And at the resonant frequencies, even very small forces can produce very large amplitude vibrations. And I think the 17 or 1800s, they found that a company of soldiers marching in step across a bridge can create a vibration that resonates with the mechanical bonds that hold the bridge together. And the bridge simply collapses because of the resonance of foots in step. So to this day, soldiers marching across a bridge break step when they get to the bridge. You've all seen the trick where a singer sings a note that is sustained, and it has to be pretty precise, very precise, that breaks a lead crystal glass. And the reason that trick works was explained by my chemistry teacher, where there's a frequency that holds lead atoms together in a crystal matrix. The lead atoms bonds, the bonds between the lead atoms vibrate with the singer's note if it's precise and it's sustained, and the lead crystal comes apart. Okay, that's resonance. Well, biologic resonance just explains the effects on living tissue. So if you take an ibuprofen, it doesn't just work on inflammation out in your blood. It works on the cells that create inflammation. So ibuprofen lands on this receptor that is responding to something in your system that causes the cells to create inflammation. The ibuprofen binds chemically with the receptor like a key in a lock and reduces the amount of inflammation that cell produces. Well, the frequencies act like your key remote, changing that lock with an electromagnetic signal. We think that's how the frequencies work, to change membrane protein configuration and cell function electromagnetically with a frequency specific signal. Biggest problem we have is how it is that somebody in 1922 decided that 396 hertz was the frequency that would resonate with the membranes on a nerve. Now, if you think about it, all of you or most of you have used resonance to change function. Your key remote sends a signal exactly and only to one car, only to your car. Even if there are 12 identical Subarus in a row, your remote opens only your car with a frequency that's tuned only to your car. We think that's how it works. So if you used a key remote, you've used resonance to change function. So I've been treating CRPS and RSD since about 1998. Now, most of you know the basics. It's the sympathetic nerves are affected by some peripheral injury, whether it's a fracture, compression from a cast or a needle stick or a sprain or whatever. You have nerve pain that's exquisite, soft touch is especially painful, temperature changes in the affected limb, and the affected area is often no longer connected to the brain motor center. The input from that limb stops at the thalamus and the brain centers. So they asked me not to spend too much time on the science of it, but the sympathetic nerves regulate vasoconstriction and sweating, so stage fright. They secrete epinephrine and norepinephrine to receptors in the arteries and the sweat glands. And when a tissue becomes disconnected, so deafferented means disconnected from the nerves, the receptors proliferate. So there's the sympathetic nerves, right? There's the sweat glands. That's what they look like. The sympathetic receptors in the blood vessels have affinity. They bind to circulating epinephrine and norepinephrine from your adrenals. And they bind to the receptors and cause vasoconstriction that is unregulated by the nervous system. And these basics determined how it was that I created the treatment and what it is that we do. So blood vessels are sensitive to catecholamines secreted by the nerve and circulating catecholamines from the adrenals. Sweat glands are sensitive only to catecholamines from, or epinephrine and norepinephrine from direct nerve stimulation. So there's cold and wet, which I've only seen a few times. The sympathetics are still connected and they're hyperactive due to local inflammation. They get cold and dry when the sympathetics are disconnected and the sweat glands are denervated. So dystrophia is part of RSD because the skin can become dystrophic. The nerve dysfunction and the temperature changes can spread to the unaffected side when the pain affects the brain and disconnects from the sensory cortex and affects the representation of the hands and the feet on the opposite side. Loss of motor function is not uncommon due to both central and peripheral changes. This is a screenshot from the RSD patient that we treated in the video on YouTube. It's challenging to treat, but the positive responses so far suggest that a treatment trial with FSM is worthwhile. So on that list of frequencies I got from the osteopath who bought the practice in 1946 that came with a list from 1922, there are frequencies for the nerve. So the nerve transmits pain impulses to the spinal cord, 396. There's a frequency for the spinal cord, and it transmits sensory pain and proprioception from the periphery, and it can amplify or inhibit pain signals. Then the spinal cord transmits descending motor impulses and motor and pain inhibition. So the medulla, all motor and sensory pathways, there's an autonomic response, a stress response, both up and down. There's 84 hertz is the hindbrain or the cerebellum that coordinates movement or inhibits movement based on where your limb is in space, whether it's in pain, whether or not you can feel it. The midbrain, the thalamus, so we only have one frequency for this whole area. So the thalamus normally suppresses pain, but it amplifies chronic pain. The hippocampus is emotional memories of all painful events, and the amygdala. So that we have one frequency for that whole area. There's 92, the sensory and motor cortex. We have 90, the forebrain, cognitive processing, how you think about pain and what you tell yourself about it. So different professions address different parts of this in different ways. FSM does it with frequencies. So pain processing is not as simple as you think. And if you look at itching, the nerve is irritated by histamine or inflammation. Well, the cord transmits the signal. It's either normal or amplified. The periaqueductal gray, this little thing, modulates pain intensity. So it can increase it or suppress it depending on what's going on. The insula in the midbrain. So we have one frequency for all of this. Assessment of the pain intensity. Is it 3 or is it an 8? The thalamus normally suppresses pain, but it can amplify pain when the pain has become chronic enough. So anterior cingulate, is it appropriate to scratch? Is it appropriate to behave a certain way when in response to the pain, right? Prefrontal cortex decides how good is this going to feel. The sensory and motor cortex, where exactly is it located and how do I move? What needs to move in order for me to deal with it? The cerebellum coordinates the muscles. The spinal cord transmit messages to the muscles and from the nerve. And then the result is you scratch the exact spot. Now, the patients who have CRPS and RSD are in pain, but it uses the same pathways and similar parts of the brain are involved. So the frequencies that we use are on 2 channels. One is 40 hertz. That reduces inflammation. We have data that shows that. 181 hertz increases secretions. Now, this research was done in the ovary, and it increased salivary estrogen from 1.7 to 37.1. So we know that 81 hertz increases secretions. And then releasing scar tissue, we treat scar tissue in burn patients and in myofascial pain patients and in patients with neural adhesions. There's 10, the frequency for the spinal cord, and we have data that shows that we can affect the sympathetic nervous system. So this research was done by Dr. Bilica, as an MD, and presented at our symposium. So this was after lunch, heart rate variability. He was parasympathetic dominant. He did the frequency to quiet the parasympathetics, and he drove the parasympathetics down by about 50%. He did the frequency to increase secretions, 81 hertz, in the sympathetics, 562. So he treated for just 1 minute, and then he waited 2 minutes, and then he retested. And when you increase the sympathetics, it drove the parasympathetics almost to nothing and increased sympathetic tone. Then he increased increased secretions and vitality, 49 hertz is vitality, in the parasympathetics. And that took everything back to the way it was in the beginning. That's 1 minute treatment, 2 minute rest, and then retest. So when we treat CRPS, if you think about the mechanisms that we talked about, you want to quiet the sympathetics, you want to quiet the inflammation and the activity in the nerves. You want to quiet 40 hertz in the spinal cord, because the spinal cord becomes amplified or sensitized to pain. The cerebellum coordinates movement, or it inhibits movement based on pain and nerve adhesions. The midbrain does pain suppression, and in CRPS, there's central or thalamic sensitization. The sensory and motor cortex is sensory awareness, and it initiates movement. And then the frontal cortex is cognitive processing and judgment. So that's 90 hertz. So you're going to see the treatment protocols that are coming up that use all of those. So cold and wet RSD I've only seen, or CRPS I've only seen probably a handful of times. And it has always been, one was a sprained ankle, the others were wrist sprains. And it was all within 24 to 48 hours, and the patient was cold and wet. And the approach was simply to reduce the inflammation. So these are in bold. Reduce the inflammation in the sympathetics, reduce the inflammation in the nerve. And for some reason, nerves prefer the current to be polarized positive. And then we treated the precipitating injury, which would be the wrist sprain. And you treat whatever peripheral injury caused the inflammation. I've never had this fail. It's an early phase, and it's unusual to catch this condition this quickly. Cold and wet hasn't centralized. And then once you get the nerve quiet, then you want the nerve to reconnect with the peripheral tissue appropriately. So we increase secretions in the nerve, reconnect the nerve to the sweat glands and the sensory receptors. That tends to restore motor and sensory function and seems to normalize what's going on in the periphery. Now, when we treat CRPS that is cold and dry, we always use 2 units. 1 unit goes from neck to feet, like this, to reduce spinal cord sensitization. And sensitization just means that the spinal cord is going to transmit pain messages more easily and more enthusiastically than it would otherwise, and quiet central sensitization in the thalamus. So those run neck to feet because they're central. And then the second unit treats the periphery. So most of you will know that the sympathetic nerves are in the thoracic spine. And so we want one contact. This towel is wet and warm. We place it on the patient's back. Then we have the patient roll over on their back. Then there's a contact around the neck. So that, say this patient has RSD or CRPS in the left arm, and you need to treat from where the nerve starts to where the nerve ends. And we use reduce inflammation in the nerve, reduce inflammation in the sympathetics. This is, the contact is on the low back where the nerve starts. And this patient has CRPS in the lower leg of the foot. And then you can use the frequencies to increase secretions in the nerve and the sympathetics ultimately. But that's how the contacts are set up. Microamperage current is current you can't feel. It's the same kind of current that your body produces on its own. So it's physiologic. It's not like a TENS unit. It's classified as a TENS unit because that's the way the FDA approved it. But it's current you can't feel. So in some patients that are on opiates are not particularly effective for nerve pain, but they're used a lot because it dulls the effect of the pain. Sometimes we have to use the frequencies to neutralize the effects of narcotics on the cell signaling. And we do those frequencies in the spinal cord and the nerve. But the thing that is done the most is reduce inflammation in the nerve and reduce inflammation in the sympathetics. Now, you run from the spine to the periphery, to the arm or the leg or wherever. And then you polarize it positive because that makes the nerve normalize. And as you run this, the area of sensitization, the area where the soft touch is particularly bothersome, that begins to shrink. And when you watch the video on YouTube, you'll watch me measure it and you follow it down as it shrinks. And then every now and then, the problem is that the nerve is disconnected and 40 isn't what that patient needs. Sometimes we'll use increased secretions in the nerve from the spine to the affected limb, and that reconnects it with the periphery. And when I say for as long as it takes, when I treat a CRPS patient, it takes 1 to 2 hours to get it gone. And that is, you'll see that in the video. You polarize the spinal cord, reduce inflammation in the spinal cord, polarize positive. Once that's the second unit. And then once the pain is down to between a 0 and a 1, then your job is to reconnect the sympathetics. So remember, the problem is that the sympathetics and the peripheral nerve has disconnected from the peripheral tissue, let's say in this wrist or in the leg, which is in the YouTube video. So increased secretions in the sympathetics and the nerve, that drives the nerve to reconnect with the periphery. And then it's a matter of increasing motor function. So it may take 1 hour to up to 90 minutes to reduce the pain and normalize the temperature. So while you're checking with the pain and the sensation, you're also checking for temperature. So the pain pathways from central to peripheral, 92 is the sensory and motor cortex in our world. It processes sensory and pain information and it initiates motor action. Everything then goes through the thalamus or the midbrain, and the midbrain decides, is it safe to move this tissue? Is the tissue painful or is it not painful? That's the thalamus. The hindbrain or the cerebellum coordinates or inhibits movement based on proprioception, position sense, where is it in space, pain and sensation. Then the medulla is the part of the brain and the brainstem that contains all the motor and sensory pathways, creates the autonomic responses and the stress response. Then there's 10 hertz. These are all hertz frequencies. Spinal cord transmits sensory pain proprioception from the periphery of the brain. It can amplify or inhibit pain signals. And then it transmits descending motor impulses and motor and pain inhibition. And the frequency responses suggest that we can affect the spinal cord pretty dramatically. 396 hertz is the peripheral nerve, and we've been treating neuropathic pain since about 1998. So we're really successful with it. We just have that one published paper. So cold and dry, RSD, once you get the sensation normalized, the temperature's normalized, then you need to quiet the thalamic representation, because pretty much the peripheral tissue is only represented in the pain centers in the midbrain, right? So you quiet the thalamus until the patient gets used to there not being any pain. So basically the only representation for this limb, whether it's an arm or a leg, is in the thalamic pain centers. They're disconnected from the sensory and motor cortex, especially if you've lost motor function in this peripheral limb. So the limb will feel numb and the patient can't find it with their sensory cortex. And it feels really weird in adults, but it has been especially bothersome when I've treated children. Once we get them out of pain and they can't find it in the sensory cortex, you have to treat the sensory cortex pretty quickly. So if there's bilateral spread, so it started in the right leg, but now it's also starting in the left foot and both hands ache, then you quiet down the representation in the sensory cortex. Then to restore motion, so for those of you that have lost motor function, Frequency Specific has experience that says that when we increase secretions in the sensory and motor cortex, it restores motion fairly quickly. The first time I did this was probably 2001 with a patient that was an employee. Every time we got her out of pain, she would fall because there was no motor function in her affected leg. One day, I ran the frequency to increase secretions in the sensory motor cortex, and in seconds, her right foot began to move normally. Inside of a week, she had hair back on her leg, and it was pretty spectacular, actually. Have the patient move the limb while we're running the current, and you're running increased secretions in the sensory and motor cortex. I have, upon occasion, placed the contact at the ear, even though we don't usually run current to the brain, as long as there's no history of seizures. If there's any concern, it seems to work just fine if you place the contacts to the neck and the peripheral limb. And then you start retraining movement by increasing secretions in the cerebellum. So first you get it connected in the sensory and motor cortex, and the sensory and motor cortex says, I want to move my hand or my arm or my leg. And then the cerebellum, we increase secretions in the cerebellum, and the cerebellum begins to increase, apparently, its secretions. That begins to coordinate movement. Then you increase secretions in the nerve to increase the motor activity to the muscle, increase secretions in the muscle itself, 46 is the sarcomere. Then you increase secretions in the spinal cord to support sensory and motor cord pathways and reconnect them to the periphery. Then you'll see this in the video on YouTube, release the adhesions in the nerve and allow for normal motion, because the cerebellum is not going to let you move a nerve that is adhered, is not going to let you move a muscle that is adhered to a nerve. So we have a published paper on resolving chronic pain and adhesions after ulnar transposition surgery. You can look that up. It was published in a physiotherapy journal. The patient was a year after an ulnar transposition surgery. And when you're treating for adhesions in the periphery, you need to move the limb gently and slowly, and you need to mobilize the soft tissue. This is me working on our patient. He had CRPS, his tib anterior was disconnected. The peripheral nerve that was affected was a cutaneous branch of one of the tibial nerves. And we had to get rid of the adhesions between the nerve and the surrounding fascia. If it's in the arm, you'd work on the nerve this way. If you're dissolving the adhesions and it kicks the pain up, you reduce inflammation in the nerve. Then in a perfect world, to get it to last, you always address the instigating factors: disc bulges, bone bruises, needle sticks. One patient had a tetanus shot, ankle or wrist pain. It just depends. Nerve traction injuries or direct nerve trauma are the exception, because that is the injury. Now there's side effects. They'll get shivering or goosebumps with just the sympathetics overshoot. So you quiet the sympathetics 40 and 562. And as you'll see in the video, you don't have to do anything. You just sit there and watch it and wait, because the frequencies have a very direct effect. All of you know that soft touch is exquisitely painful. Firm touch is okay. Those of you that are therapists already know this if you're treating CRPS. Once the sensation returns, and you'll see in the video, we have to teach them to walk again. And we'll use increased secretions in the cerebellum and the sensory and motor cortex. Now, the feeling with movement while they're walking, sometimes we'll follow them down the hall with the unit working. Feeling of congestion remains, and that's a characteristic of deafferentation injuries. And you treat over time for the nerve, the cord, the sensory cortex, the periphery, to get it normalized. And this is the video on YouTube. This is actually my son. He had surgery on his knee, and they injured one of the cutaneous branches. And so he had CRPS for 11 years. And in the video, you'll see that it was resolved permanently in his case in about an hour and 15 or 20 minutes. And I go through the diagnosis, the treatment, and you'll watch us do the gait retraining. And yes, I'm wearing the same jacket in 2014 that I'm wearing today. Children seem to respond differently. So sometimes you have to modify treatment with children. We have pediatric rehab at Cleveland Clinic that's been using FSM for about 8 years. So the follow-up, you address the central component, because being pain-free is going to feel strange. I feel as if I should be in pain, but I'm not. One patient actually put it in words really well. At that point, I tell the patient, if it worked the first time, there will never be a time when it doesn't work. And it's okay if you don't believe me. It's so odd to be pain-free at the end of an hour and a half. So when I have patients in the clinic, you schedule a follow-up for 3 to 4 days later. If the pain comes back, you get rid of it again. Most of the time, if you've done your job the first day, it doesn't come back. And that's even harder to believe. But you still want to see them 3 to 4 days later, so you can check in to see how they're doing mentally, emotionally, and physically with this pain-free state. You repeat the peripheral treatment as necessary until the pain is a 1 or a 2. You go back, address central sensitization again in the midbrain, the frontal lobe, the cerebellum, the sensory and motor cortex, the medulla. You might need to increase secretions in the nerve. the frequencies don't mean anything to you, so I'm just using the words. The nerve, the spinal cord, the cerebellum, the medulla, the cortex, the sensory and motor cortex, to reconnect the brain to the nerve again. You combine it with active movement. So you have to remember, those of you that have lost motor function, once a muscle hasn't moved for 1, 2, 5, 11 years, it's weak and it takes time to strengthen it. Medication management and withdrawal, that's another reason we follow up with patients. Once the pain is down to a 1 or a 2, the patient is automatically over-medicated. So I caution people, don't discontinue use of especially opiates and certain antidepressants abruptly, even if the pain stays a 1 or a 2. So then you go back to your physician and reduce the medications slowly. As the opiates and the antidepressants are reduced, pain might go back up, because remember, all those receptors have proliferated. So you schedule up follow-up appointments to maintain the pain-free state. So you have to earn the right to reduce the medication. So you schedule follow-up appointments once a week or once every 2 weeks to monitor symptoms and the patient's physical and mental recovery. RSD can become central or full body instead of affecting just a peripheral limb. There's the following case is, I've only done one of these that was spectacularly effective. RSD associated with abdominal pain appears to be coming from deafferentation or disconnection of the pain fibers of the vagus nerve and central sensitization in the thalamus. So in our world, we use quiet the thalamus, 40 and 89. 89 is the midbrain where the thalamus lives, and quiet the spinal cord sensitization. You treat that from neck to feet, since those are central and affect the whole body. And then you treat to rehabilitate the vagus with what we call vagal tone protocols. So this is a case report. The patient was 19 years old, full body pain, gastroparesis, POTS, abdominal pain. Urination felt like the urine was glass shards. She had a severe viral infection in the mouth and throat at the age of 6. She had stomach pain after that, left class daily for the nurse's office. She had constipation and gut pain daily. She had gastroparesis with vomiting at age 11. A port was installed. It leaked, so she had abdominal adhesion. She developed POTS at age 12 or 13. And then she had blood draws at age 16 that caused immediate sharp arm pain and full body pain and allodynia with hyperesthesia, full body, including her forehead and face, persisting up to the present. So she was 19 when we saw her. She'd had it for 3 years, full body pain, allodynia, full body skin hyperesthesia, even on the face, pain with soft touch everywhere, pain with eating, slow or no digestion, abdominal pain, severe pain with urination, defecation, any gut movement. Her heart rate was 90 at rest. It would go up higher than that, never went lower than that. What we had, there's a brain trust of 6 people that sat around a table in a coffee shop at the hotel the night before we were going to treat this patient. And what we found was that the vagus has pain fibers. So the vagus is pain conduction from the abdomen, as well as being in charge of heart rate, gut motility, and a lot of things. Once you see the vagus, you can't ever unsee it. So if CRPS is a denervation condition, what would happen if the vagus was disconnected from the gut? Well, she'd get gastroparesis and POTS. And what if the vagus disconnected from the gut? You would have CRPS based on the vagus disconnecting. So we used quiet the midbrain for the allodynia because it was centralized. And the vagus disconnected from the gut, and any sensation would be perceived as painful. So we treated her with 3 machines, quiet the midbrain, treat the vagus. You have to treat the original precipitating event. So we had one machine that ran just the frequency for malignant virus, on the vagus that ran for an hour, hour and a half, and then trauma in the vagus, vitality in the vagus, 30 plus minutes each. I hadn't treated many people with POTS at that point, so I didn't run increased secretions in the vagus. Now I'm much more confident with that, so I would have done that had I had the presence of mind back then. Treat the medulla, quiet the activity of the medulla because it quiets the stress and autonomic centers. So this is what we did for this girl, right? Quiet the midbrain, treat the vagus. And at the end of it, we treated for scarring in the vagus. At the end of it, after 2 hours, pain was a 0. She stood up because she really had to go to the bathroom. She had to urinate. She stood up, stopped in her tracks and said, the POTS is gone. The allodynia was gone. The sensation was normal. And that happened in the first 30 minutes. Urination was pain-free. And when she got up, her heart rate was 67. In her case, the recovery was permanent. This is an N of 1. Yeah, and this is one of my students. She was the one that did the scar tissue in the abdomen. So that one is unique. I have only seen that one case, and it's impossible. Once you do the impossible once, it's not impossible anymore. Once you do it 20 or 30 or 40 times, once it's teachable, it's not impossible. Most, I've had some failures. They recovered. There's never any guarantees. So even though I'm doing this presentation explaining what we do and why we do it, there's never any guarantees. My failures have mostly been on patients where the nerve was cut and I hadn't figured out how to treat phantom limb pain yet. Use common sense. Make sure your therapist, if you're a patient or if you are a therapist, be sensitive to the patient's pain, aware of its meaning. Firm touch. Always ask permission before you touch the patient. And there's little to use since I guess everybody listening to this, there's not much hope or help available. Getting your pain down is the best you can hope for. There's little risk medically. And ask your therapist or physician to take an FSM course and learn how to treat CRPS. I'm in the business of teaching seminars. If I was the only one that could do this, it wouldn't count. The fact that it's teachable and reproducible is the most important thing. So if you or your therapist will go to frequencyspecific.com, you'll see that webinar or the video that we did, frequencyspecific.com/RSD, and that you'll be able to watch that video. It's an hour and 15 minutes, but it's kind of fun. There's no guarantees, but at least there's hope here. So that's how do I get back here? There we go. That's my presentation. And I told you I would get done in the time allotted. You didn't believe me, did you?
I believed you.
don't
I'm bringing Jim back on as well.
Yeah.
All
See?
right.
Oh, ye of little faith.
You made it work. Well, we definitely have a good number of questions in the chat, but I'll start with you, Jim. Do you have any questions for Dr. Carol?
Well, first of all, Dr. Carol, I've been working for 2 decades for people with CRPS, and why have we waited so long to bring you here?
I did it. We finally filmed it for the first time in 2014. The challenge with CRPS is I train clinicians, and I have come to believe that a clinician would rather have a root canal without anesthesia than take the time to publish a paper. I'll fix 20 CRPS patients, but taking my nights or weekends to write up a case when nobody's going to believe it anyway, and you have to get it past reviewers that don't want to hear that it's curable. They don't get the model. It's so the fibromyalgia paper that we published in 2005, we submitted it 4 times with the title Resolution of Fibromyalgia Associated with Spine Trauma. Because the medical profession has as its basic position that fibromyalgia is incurable, I couldn't get it published with that title. The last 2 times we submitted it, the title had to be cytokine reductions with fibromyalgia associated with microcurrent treatment of fibromyalgia associated with spine trauma. So since the medical community assumes that RSD or CRPS is incurable, I'm going to take my time to write a paper, fight with the reviewers, find a journal that will publish it when they don't think it's curable and they think it's subjective and the patients are all hallucinating, especially this one that I'm doing a single case report. You can't even do a collected case report because there's so many different mechanisms and each patient's treatment is individualized. How long does it take to reduce inflammation and restore the connection? Every single patient, it's been different. And you know that in a collected case report, you have to standardize the treatment. That's impossible. So that's why.
Well, you're here now. Thank you. Alexis, please.
All righty, so I'm going to jump into a few of these questions. So someone just asked this one. She just wanted to clarify. Did she hear correctly that this will not work for a nerve that has been cut? Just wanted to clarify that.
I had one patient where her nerve damage was from a chemical burn. And when they debrided the burn tissue, they took out the peripheral nerve. That being said, so I was not successful with her. But since then, we figured out how to treat phantom limb pain. So if I were to see someone whose nerve had been scooped out, I'd try the protocol for phantom limb pain because that's actually easier than CRPS. The patient that we treated, his nerve was injured in a surgery. So I don't know if it was cut or just traumatized. And the nerve must have been at least somewhat present. So that's a good question. It's worth a try, is the thing. Can't hurt, might help.
And some of these questions, I definitely hope that I didn't miss them, but I know warriors, they come in different points of the presentation. So apologies if any of this you've already mentioned. But one of the questions we got also was, can the treatments reduce flares and prevent CRPS from spreading?
Prevent CRPS from spreading. If you fix it, it's not going to spread.
Right.
And what I tell my practitioners when I teach this section of the course is that you do it at the end of the day. You tell the patient to bring their dinner or a book, because restoring, as you'll see in the video, it's like watching grass grow. The frequencies do the work. You just track the sensation as the sensitization comes down. So yeah, the flares are related to I think, to the fact that the scar tissue between the nerve and the fascia is not corrected. And when you start moving, you pull on the nerve, that creates a nerve traction injury, that creates inflammation, and that produces the flare. Flare is in quotes. So I'd say a conditional yes. And not all FSM practitioners are equally comfortable treating RSD. So you have to check with an FSM practitioner to see if that's okay with them, if they're willing to give it a try.
Good to know. I have a few more questions, but Jim, any questions on your side?
I think the major one, Dr. Carroll, is a lot of people are financially challenged.
Oh yeah.
And how does that work? Can this be coded for insurance coverage?
Yes, it can. And you all of you know that insurance companies decide what they're going to pay for based on some random algorithm. The challenge that we have is that it takes about an hour and a half to get the CRPS gone. at least. That means you've got 4, 8, let's say 4 to 6 units of attended electrical stim. You can do it unattended, but practitioners don't get paid much. Then there's a cognitive portion. Some insurance companies have decided that they're only going to pay for 1 or 2 units. That means the practitioner has to be willing to donate 45 minutes of their time to treating that patient, knowing that they're not going to get paid for it. So treating RSD is not something you do for money. It's something you do because it's a good thing to do. Pennies in heaven, so to speak. But it is billable as a TENS. The device is approved as a TENS unit, and whether or not insurance is going to pay for it, and whether or not your practitioner knows how to treat it, that's another question.
Mhm.
Yeah.
So to follow up on that question, it sounds like you can be trained in FSM, and then it just kind of depends on, I guess, the knowledge of the practitioner, because we have some people who are asking, if FSM can treat someone who has MS or someone who has stump neuromas. I'm sure there's numerous different things. It just depends on what the practitioner is most knowledgeable about, correct?
Well, and comfortable treating. CRPS is scary if
Right.
you haven't seen it before. I've treated it so much that it doesn't scare me. Practitioners get nervous because the patient's pain level is so high. They don't understand the autonomic dysfunction. They don't understand the neurology of it. So I have to sort of lead them through that. It's the practitioner comfort level. Stump pain and phantom limb pain is fairly easy to treat. Stump neuromas are a matter of dissolving scar tissue in the nerve. Between the nerve, the blood vessel, and actually the nerves can get stuck to the bone. The periosteum is very well innervated, and it's stuck to the fleshy padding that they leave at the end of the nerve root. So I've treated neuromas a number of times. It's doable. I think I answered that. Did I get all of it?
That's cool. Just to make people feel more comfortable. Talk about some of the clinicians, centers who have adapted the FSM as part of the rehabilitation.
Well, the 2 best known are Cleveland Clinic. 3, Cincinnati Children's allows them only, the hospital allows them only to treat torticollis that we have a published paper on. And so the physical therapists and occupational therapists there are quite limited. We were lucky that Cleveland Clinic had an integrative care center and an MD and 2 DOs, plus the physical therapy staff that were quite enthusiastic about the results they saw. So Cleveland Clinic is the biggest center. One of the MDs from Cleveland Clinic went to Shirley Ryan, and he's starting to use that in pediatric PM&R. He treats RSD quite often. So I'm assuming he's using RSD in his treatment protocols. Everyone else I treat is in private practice or in a small individual clinic. I've been teaching it since 1997. So what is that, 25 years?
Mhm.
It was really pretty bad for about the first 10 years, I think. And I have a feeling that I really only got good at teaching it in the last 5 years. So I want everybody that took it back in 2000 to come back and take it again. And so that's going to determine whether or not they are comfortable treating it. And the RSD video has been watched almost 20,000 times, 19,700 and some odd. So practitioners who are treating CRPS watch the video and follow the steps, and then they can go to the slides that are in my core seminar.
And you sadly told us that you cannot see patients till next April. But
March, I signed myself out for a 2-week vacation. And so I just saw in our electronic medical records that I'm beginning to book patients into April. I'm really sorry. And I only see 3 patients a day. I'm 76. I mean, I got to get real at some point, right? But I will work with, by way of email or phone, any practitioner in the country or in any country that is seeing a CRPS patient. I'll send them the slides, the updated slides. They can watch the video, and it's really just a matter of getting comfortable with the patient and with the condition.
So I have 2 more questions because we are just over an hour and I feel like we could stay here all evening. So second to last question, I assume I know the answer, but just want to double check. Can you go through FSM treatment if you have a spinal cord stimulator?
Yes. And spinal cord stimulators, I had one patient who had a morphine pump, and spinal cord stimulators all have an off button. You just turn them off. And the same thing with the morphine pump, you just turn them off. Baclofen pumps in patients that have ALS don't have an off switch, but I've never had a problem with that. And you asked a question about MS. The challenge we have is you can't put tissue back that's not there. So slowing progression with MS is realistic based on the cytokine data. For someone that is using a technique that is so outside the norm of what we usually do, I am very data driven. So I like the data that we have. So we know for sure that we can reduce inflammatory cytokines. So we run reduce inflammation in the spinal cord, reduce inflammation in the brain parts, put the patient on an anti-inflammatory diet, increase essential fatty acids, make sure their vitamin D levels are normal, and do what we can to reduce spasticity, reduce pain, reduce inflammation, and slow progression. So MS and ALS are an entirely different critter than nerve pain is honestly the easiest thing we treat. It's easier than anything else. And it's time dependent. The C2 nerve root is 15 minutes. The arm is 30. The leg is 40 to 45. The body is 60. And I would love to find somebody with a squid axon that can tell me why it's time dependent and what it is we're doing exactly. That's in a perfect world.
All righty. Final question for the evening. What results have you had with patients who have had CRPS for 10, 20, 30 years?
I'd say the longest one I've seen is 13 to 15 years.
Okay.
And it really depends on how it started, what has been done since it started. And it's not likely to be a one visit fix. That's for sure. So my son had CRPS for 11 years, and I had treated it, but never gotten it completely gone because he wouldn't sit still long enough. So this time it was an hour and 16 minutes, and it was permanent. It never came back. So like 20 years, I don't know. I'm willing to try. Is it going to work? I don't know. I'm willing to try if the patient's willing to try. Can't hurt, might help.
Okay. And just final question, Dr. Carroll. When they search out the practitioners, are there specific levels of training they should look for, or just a comfort level that's been trained by you and they're comfortable treating CRPS?
The practitioners who have taken the course most recently will have the best training. Patients who have done the advanced or who are certified. So the patients who are certified have a written exam. They have to submit 10 written cases, and they have to have attended the core seminar twice and at least one seminar either in person or on video. So some of our practitioners in Europe, Taiwan, Kuwait, Australia, Germany can't come to meetings in person, so we allow them to do it on video. So once you find somebody in your area, find out when they took the course, and that's available on the website if the website is working right. When they took the course, have they taken the advanced, and then call the office and ask them, do you still do FSM? And do you treat RSD? So that would be the steps. That's a good question. Is that it?
Yep, that's it. So thank you, Dr. Carol, for all of this great information. As always, everyone, we will have this video pinned to the top of our Facebook timeline for easy access if you want to rewatch. We will also add it to our YouTube channel. We will also add a link to the presentation there as well. Of course, if you have any questions for us, if you need a support group, if you're looking for a new physician, or if you want to tell your story on the RSDSA blog, please send us an email at info@rsds.org. Have a great evening, everyone.
Thank you.